Well, again, I'm Clark Lewis. Good morning. And I didn't know the hardest thing would be probably getting on the stage this morning for me, but we really appreciate y'all being here today. It was a very informative opening remarks, and we'd like to turn our attention to this great panel we have before you today. You heard a lot of comments about myself and our law firm, but what I'd like to do is ask our very distinguished panel working from my left just to briefly introduce yourself, tell us about your company, and we'll go from there. Thank you. Todd?
Great. Todd Stottlemyre. I got to tell you, I had a chance to say hi to Dan Polino when he left. Dan's a really talented guy. I've known him a long time, but I didn't think he was going to start to sing Alice Cooper's School's Out for Summer, but anyway, he shouldn't do that. I'm the CEO of the Inova Center for Personalized Health, which is the newest Inova campus, 117-acre campus right across from our flagship campus, the Inova Fairfax Medical Campus. We took possession of this campus, the former ExxonMobil headquarters, in October, and we are building the new Inova Center for Personalized Health on this campus. And this campus is fundamentally focused on how do you keep healthy people healthy and use science, omics, genomics, proteomics, and data to predict and prevent disease and then treat disease on a very individualized, personalized basis.
I'm Tom Auer. I'm the CEO of the Bon Secours Virginia Medical Group. I'm a family physician. Can you hear me? I don't know. I'm a family physician by background and training, and the Bon Secours Medical Group has moving away here. 185 locations across Virginia, from Richmond to the coast, from Blackstone to Eastville in the northern neck. We have about 700 providers, 60% primary care, 40% specialists, and we've been on a journey to transform the healthcare that we provide in order to transform the healthcare for our patients and the health of our communities. And in this process, we've changed dramatically our approach, and we'll be talking about that as the panel goes on. But we're dedicated to providing really good help to those in need and really focus on the poor and vulnerable in this community. So we're really pleased to be here.
Morning, everyone. My name is Marie Manning. I'm the Director of Product Development and Research at Optima Health. I've been with Optima Health since 2013, and it's really been a real enlightening and dynamic experience for me. I'm pleased to be here this morning. I'll tell you a little bit about Optima Health. Our head offices are based in Virginia Beach, beautiful Virginia Beach, and we offer a full suite of commercial products across all the segments, individual and family, all the employer groups. We offer Medicare and Medicaid plans. Our membership base exceeds 450,000 members, and we have a deep provider network, well over 25,000 providers, health system, medical centers, you name it. Now, we believe in innovation and technology, and we believe that the two have a very central part in how we move forward, how we grow, and how we better serve the communities that we're based in. So the discussion today, we're looking forward to speaking to how those pieces come together and the work we're doing and how we can better help our members to achieve their best health.
Good morning. I'm Liz Martin. I'm the Vice President for Riverside Health System. We're based in Hampton Roads, Virginia. My responsibilities are for quality, care management, and telehealth services across our region. We serve the Newport News, Hampton Roads area, as well as several rural communities, such as the Northern Neck, the North Peninsula, and the Eastern Shore, to include Tangier Island, even out there. Our health system celebrated its 101st birthday population health strategies to meet the needs of consumers one patient at a time.
Hi, and I'm Mark Carbo. I'm CEO of Interleukin Genetics. Our company develops novel genetic tests that are used to help provide insights to prevent disease and in some cases to help caregivers manage diseases. And we're specific in the inflammatory cascade, so diseases that are mediated by inflammation. So that takes in quite a lot. Things like cardiovascular disease, diabetes, obesity is now implicated through the inflammation cascade and so on. In addition, though, to the genetic insights, we find that it's important to really drive engagement. And so we've created a suite of digital health tools that are directed toward outreach to high-risk members. So we're providing a risk stratification framework that then identifies people who would benefit from different care interventions and coupling that with digital health tools to drive engagement and compliance around those new pathways. So very delighted to be with you all today. Thank you.
Great, thank you, panel. Todd, let's start with you, since you're right next to me. And I can ask you, tell us how technology is improving access to care, healthcare, and particularly the delivery of personalized medicine. And again, I'll work our way to the left after you conclude your remarks. Thank you.
Yeah, I mean, to me, it really is a data game, and it's not data as much as it is how do you take data and turn it into actionable information. So everything that we're doing on the new campus and throughout the healthcare system, it's not just the science, it's not just the advancements taking place in genomics, omics, if you will, but it's data. And as Dan said earlier, it's data from multiple sources. It's not just clinical data, it's environmental data, familial history, psychosocial data. It is a very, very broad data set. And how do we take this data and then turn it into actionable information that we can actually impact clinical decisions at the bedside in terms of care? So the investments that we have made in technology and continue to make are absolutely foundational and critical to everything that we're doing as a healthcare system, and very importantly, everything that we're doing on the new Center for Personalized Health.
Great. Doctor?
We're in, in our journey, are all talking about the next generation of healthcare, which is population health meets total access. And so our job is really, as Dan talked about in the world of consumerism, is how do we allow the consumer to really pick the place to enter into the healthcare system, and how do we use technology to do that? We're all on Epic in our organization. We've been on Epic for the last 6-7 years now, and that allows us to communicate internally and allow people to see information across the system, both on the acute care side as well on the ambulatory side. We used to be a 8 to 5 organization. We've expanded hours in almost every one of our practices and location to have the traditional healthcare delivery system be more available. We've added nurse practitioner run retail centers in several of our food stores that have been very, very helpful in expanding our hours and availability. But the real key is going into BondScore 24/7, which is a telehealth platform that allows us to be available 24 hours a day, 7 days a week to our patients. For $49, they can come and see us and enter our system. That then can generate a relationship with the rest of the organization and get them back into our system in an appropriate way. The leveraging of that technology has been amazing. We've been only live on that since January. We've had over 5,000 people download it. Of those 5,000, the oldest is a 92-year-old. And so for people who think that technology is for the young, our visit volume peak is between the 45 and 55-year-olds, 70% women. So it really is an amazing move, taking that platform and then using it in other ways, integrating it with behavioral health, integrating it in other systems is the future, I think, to allow the consumer to pick the way they want to access the care with us.
Thank you, Doctor. Marie?
So throughout the presentations that we listened to this morning, we've all heard the same cry. Care is fragmented. There are significant costs linked to how we treat patients today. This is something that we've been paying very close attention to at our health plan, and we've been working very closely with our providers in a collaborative manner to address a lot of the concerns that we've been hearing about and we've been seeing on a day-to-day basis. And so we have what we call the Centera Quality Care Network, which is a collaborative effort across our provider groups to treat patients, to share data, to focus on information that providers or physicians typically do not have access to. You're talking about historically, a physician is only seeing the information that they would request a patient go out and test for. What we've done is we've aggregated this information under patient registry, using data analytics, using sophisticated technology platforms. We've aggregated this information in a way that enables our physicians to access this information, to use it, and to treat patients in a manner that is efficient, in a manner that is on point, and in a manner that is driving significant results. And I'll get into some of those details a little bit more as the discussion continues.
Without being too repetitive, some of the strategies that we're using within Riverside to help technology improve access are through telemedicine services. We are offering virtual visit services for about a year now, a similar platform to do your description, where people can access immediate urgent care needs for minor illnesses. And that certainly is helpful in meeting the convenience needs of our consumers and keeping people at work and letting them get their visit on the over lunch hour or whenever it's most convenient for them. But also tying those access points back to their primary medical home and making sure that that is delivered in a way that covers the continuum of care so that that information gets shared back with their primary medical home to be sure we can tie up any loose ends that that patient may need. We're also using that virtual technology to do post-op visits for our patients so that they don't have to come in for something that doesn't require a physical exam, or a patient who may have a new diagnosis of depression, may have some medications that we're trying. Those which frequently don't come back to the office when you need them to. And so there's virtual visits, ways of connecting with them. How are you doing? Do we need to tweak your medications, et cetera? So utilizing a lot of that mobile technology that we now have at our fingertips is now very affordable to really improve access for patients. We have a lot of examples I think we'll be talking through this morning.
Mark?
Great, and I think our themes are similar where we have, I think our contribution is partly to take the science but make that science actionable, and particularly in a care delivery sense. I think there's a real opportunity to think about coordination of care between different disciplines, and we sometimes miss that. And with genetics insights, we can identify high-risk people, and then we can direct more attention towards outreach to try to get those people to coordinate care better, to provide different care and different engagement. Interestingly, in managing inflammation, inflammation is now implicated in many, many chronic diseases. What are the ways that we can manage inflammation? There are some therapeutics emerging, though many of them are in development. There are things we can do on a lifestyle basis. But interestingly, a very practical access point to lower chronic inflammation is better dental care. And is the dentist really on the care team for the diabetic patient? Well, no, not generally. But yet, 30% of your systemic inflammatory burden is created by inflammation in your gums. And so now, through science, we know that if we manage that inflammation in your gums, we can reduce the onset of type 2 diabetes. We can reduce the progression or slow the progression of diabetes, and in some cases, reverse it. And so through genetics, we identify that insight, but that isn't good enough. We have to make it actionable, right? And so we need to help the care team understand that there is that linkage, and in this particular specific patient, we need to manage that patient differently in a more holistic way that coordinates care between the medical team and the dental team. And so our business is really around providing that genetic insight but also providing education to the care team on that specific patient's case, and also digital health tools to drive that patient to behave differently. So I think technology can help us on the science side, but technology is also helping us on care delivery, on how we allocate resource and how we direct care to those who need it most.
Great. Todd, let's start back with you again. Talk to us about personalized medicine policy ecosystem and what needs to be done to support it. And we were talking about great issues like payer reimbursement, privacy, ethics. So start us on that conversation.
Sure. One last comment on the last question related to technology. I've spent most of my life in technology, and I will say that healthcare is a late adopter of information technology and a very late adopter of robust analytical tools to take data and turn it into actual information. There are many, many sectors of our economy that are a lot further ahead than healthcare. So we have some catching up to do. I mean, putting EMR systems in and getting the pipes to work, if you will, is interesting, but that's just getting data workflow. What's really interesting is how do you take that data and make it actionable in terms of better clinical care and coordinated care. The ecosystem, science and technology always run faster than public policy. Always have, always will. And I think it's in this case as well, and you probably would agree that on the genetic side, that science and technology are running much faster than public policy. So payer reimbursement. Payer reimbursement is a challenge when you have genetic tests that have clear medical efficacy, clinical efficacy to get those reimbursement for those tests. So the payer reimbursement system has to catch up with where we are in the omics space. Non-discrimination. Today, if you apply for life insurance or disability insurance, it's not uncommon to see a question that says, have you had genetic testing done? Right, so if we use genetic testing in the right way to actually predict and prevent disease, not just treat disease, it's something that in the long term actually reduce costs. But the non-discrimination piece is very important because today, for life insurance and disability insurance purposes, you can't be discriminated against. So that has to change. Privacy. I mean, all this data, information, it's not just sitting on enterprise networks, it's sitting on mobile devices. So how do we protect that information, that privacy environment? And then the last issue, ethics. We're giving patients and consumers more information today, and they're getting more information than they ever had before. How do we make sure that we have genetic counselors and others that are actually working with people when they have this types of information so they can make very, very good choices? And reimbursement, for example, is an issue there as well, because not all genetic counseling is actually reimbursed. So the fundamental message is the policy ecosystem has to catch up to where the technology and the science is today, because the technology and the science are going to continue to move very fast, very quick, and public policy has to catch up.
Doctor, thank you.
I think when we talk about personalized activity and personalized interventions, the things that we're using that have been very, very helpful is a program called Vitel, which actually is now owned by IBM, and we've worked with Dan a long time, and I'm not advertising for Dan, but what it allows us to do is really reach out in a very specific way to those patients that we don't see. And part of what was missing in the old delivery system of healthcare was we took care of patients that got in our office very, very well, but we didn't do a very good job of taking care of those patients who didn't come to our office. And we needed systems and technologies to allow us to go find those folks and outreach. So we use Vitel as a methodology to scrub our databases and find, using algorithms, those patients who need care, and we can go out and find them. We have about 200,000 patients that use MyChart, which is our patient portal. That gives us another vehicle to interact with the patients in a very personal way so that we can give them their medical record, and we can help answer questions that are very interactive so patients can interface with us in a very unique way. We utilize OpenNote, which is a very effective way of pushing to the patient as soon as they've been seen and their care has been done. We push that note out to them so they can actually see the note that the provider wrote, not only in the primary care office or specialty office, but in the ED. They can see their discharge summary from the hospital, if you will. and it allows them to be much more integrated in their care. And if they're coming back for a follow-on visit, they can go back and read that history and physical and note that the provider wrote and be more prepared the next time and understand those medications that they're on in a more robust way. So really trying to focus on giving the individual person what they need when they need it.
Marie?
Yeah, and I think we all agree that personalized touch points, personalized healthcare is the way to go. I think we all agree that our ability to reach out to our members where they are, through telehealth, a visit to their home, have them in the office, meet them where they are, to the extent that we can expand those channels of contact and meet members where they need to be. I think that's one way that we're going to keep advancing our care for patients. Now, that's something we're certainly doing on our side, and we're seeing some good results there. And we agree that there are challenges in personalized medicine because there are so many folks, and you can, think this through yourself, but there are so many folks sometimes who are stuck in the past in terms of this is the way we've done it in the past, this is the way it's worked, and we're not that keen on trying some new, even if they're proven ways of treating and caring for patients. So there are the opportunities to educate our different stakeholder groups and see how we can share past successes with them and get in the weeds a little bit on this is what's worked for treating specific conditions. These are how we've approached some of our higher utilizers, our higher risk patients, and these are some of the advances we've seen. So we've seen opportunities and we've seen results, and we've been able to get down to specifics, and we're working with our stakeholder groups to keep advancing the movement around personalized medicine, because we're a big believer that that's the way to go.
Great. Liz?
From a policy perspective, when we talk about personalizing care, a lot of that is about relationship building. Certainly data drives a lot of what we do and helps us to understand risks and define personalized plans for patients on a continuous basis and to continually evolve as we learn more things about patients, whether it's social determinants that are impacting the patient, whether it's something functional or whether it's clinical. So we're continuing to want to provide those personalized levels of care. But what's changing in the environment is how we manage that. The care management strategies around that are not always physician-based. They're not always licensed professionals who need to provide those services. And the reimbursement systems are not really designed to support those different models of delivering that personalized level of care. So from a perspective of where policy needs to be thinking through is expanding that healthcare team, whether it's the dentist or whether it's that social worker or local CSP program that is supporting this patient, looking at how we can support that relationship that we're building with the patient over time to coach them through the right steps to help them optimize their health outcomes.
It's interesting. I think a lot of the challenges we see in what we implement is around complexity, and there are all these human elements that make it very real. And the human touch of the caring provider is really what is the layer of personalization. Our approach to try to manage that complexity is to really work hard on risk stratification so that we look at what are the real factors that are adding risk, generating risk, and how do we sort of scientifically validate then what is the right level of care for that individual. So it's not really personalized, it's sort of cohort by cohort, sort of compartmentalizing. The personalization then, in our view, occurs at the point of care with the caregiver. And so we're leaving to their discretion. We're trying to inform and educate them so that with this additional risk data, they're in a position to make a very personalized judgment. The other point of personalization is around how the patient, how we communicate this information, or how the caregiver communicates this information to the patient. And so we do a lot of behavioral study work to understand who likes to be messaged how and what is the motivation. And it does become fairly personalized. Different people have very different ways in which they want that information conveyed. So getting smarter about that faster, so that we can make that easier for the caregiver to have that communication, we think is a way to facilitate this. I do agree with the earlier comments on public policy pieces. Having the framework in place around privacy, around use of data, around data security, those are all important pieces that, are friction points if we don't solve those. And the frameworks are there, but we can enhance those as well.
Great.
May I just make another
sir.
comment? One of the areas where I think we really need some help in the public policy arena is making it far easier for us to be reimbursed in integrating behavioral health in a primary care practice office. It's a real challenge. I think there's a whole lot of movement and excitement around moving in that direction, but it's really the reimbursement that keeps us from expanding that kind of care. We run both an acute care facility, inpatient psychiatric, and high-intensity psychiatric service, but that's not where the action is. The action is really in a primary care practice, in our pediatric specialty practice, where if you can put behavioral health there effectively, you can have better outcomes, and we need help with the reimbursement models.
Great.
And I would interject just to pick up on that too. I think the layer of this that is prevention is sometimes difficult to know how to prioritize and how to manage. So we're built in a insurance reimbursement that's reimbursement for services. Well, who makes those investments in prevention? And is the employer prepared to front that where they have employee turnover? And so I think we're still grappling as a society with really what do we make as investments in prevention, who pays for those, and what are those incentives? So that may be another layer of complexity we'll work through collectively.
I'm going to just throw a couple of quick topics for the panel before we start winding down. But we hear a lot about telehealth, telemedicine. Can you just briefly, and I'll just kick it up to anybody in the panel, tell your experiences of this, obviously new way of practicing medicine, and where you see the future of this great.
Do you want to start, and then I'll take it over that?
We've been involved in telehealth for probably a decade now, and in Virginia, we've really had a great environment of legislators who supported telehealth reimbursement changes over time. Great leaders like Karen at UVA and others who really paved the way for us. So I feel fortunate to be in this state with progressive thinkers on that area. But in our organization, serving many rural regions, we've utilized telepresence kind of
Yeah, I would agree. I think that it's just an exciting world. I grew up in a time where you didn't do telephone monitoring. You needed to lay hands on the patient to do an exam and a diagnosis. This is a new world, and it is very effective and very facilitative. And the add-ons that you can literally do almost a complete physical virtually in this arena. A home health and hospice outreach. The acceptance by the patient, there's a lot of good literature now that patients are accepting this intervention very, very well. And as more and more Skype family members and they get used to that medium, it's just another way of us being able to bring to the consumer on their terms quality healthcare in a delivery mode. And so you're going to be seeing a lot more of this in many, many venues. The telemedicine platforms are getting so good that it allows us to just be almost everywhere all the time. And that's a challenging new world for the delivery system to figure out.
I just add, I think it's tele everything, but it's not just tele by itself. It's actually sensor technology.
Yep.
I mean, I'm an Apple zealot. This is a fun little watch, but it's basically unconnected. But think about sensors. You know who's one of the biggest investors in healthcare right now? Under Armour. Hundreds of millions of dollars going to hell. Why? Smart clothing.
Yep.
You can actually, in one piece of paper, you can put massive amounts of electronics into an iron-on patch that allows you to monitor vitals remotely 24/7. So think about sensor technology in combination with what we've traditionally thought about telehealth. I think there's going to be great disruption to healthcare from the outside in, not the inside out in this area.
Anybody else? One of the last questions I think we're going to talk about is some of the things that we could do more or do better. But before we go to that question, Todd, there's something I wanted to ask you about, and that's the global genomics. How do we say that?
Genomics.
There you go.
Yeah,
Environment.
yeah.
The Institute. How about that? And the Commonwealth's financial support and for higher ed. And I think they were a good partner. Can you just tell us about that, and then we'll turn our attention to what government can do more?
Sure, yeah. So the Global Genomics and Bioinformatics Research Institute has been created on the new Inova Center for Personalized Health. It's something, an Inova initiative, and the Commonwealth has agreed to make investments. And the investments are really around collaboration between universities and Inova and other partners, not just Inova, but particularly in the area of joint recruitment, genomics, bioinformatics, joint research, and joint opportunities. I've had the privilege of serving on a couple university boards. We have great universities in the Commonwealth. We really do. They operate very independently, and we need a lot more of this as opposed to living in silos. And so this is really an opportunity for more collaboration amongst the research universities in the Commonwealth that focus on genomics and bioinformatics, and then a whole ecosystem working with us and other healthcare partners around the Commonwealth and outside the Commonwealth. So it's really to try to help change behavior and incentivize research collaborations, incentivize collaborations around joint recruitment of eminent scientists, scholars, researchers, clinicians into the Commonwealth of Virginia.
Great.
And I see Secretary Hazel here, so thank you.
Any other members of the panel want to illustrate some positive outcomes of the great partnership interaction with our local and state governments?
I think one of the things that's emerging is the work around opioid abuse and figuring out how we can intervene in that area, and the merging of the use of Suboxone and creating Suboxone clinics and other technologies. I think this is an area where there's just needs to be a tremendous amount of emphasis in how can we as a system deliver better care to a problem that we've created and we need to solve. And I think there's a lot of good work developing and a lot of good work being supported by the local governments.
Great. And to wrap up here, Todd, why don't we start with you and we'll work our way across again. What single trend in technology and personalized medicine do you think is not being recognized by state or federal lawmakers? And in your opinion, how should they react?
Well, two thoughts. One is on the genetics side, the genomics side. We have a genetics lab, a genomics lab at Inova. If you have cancer, if you're diagnosed, the first thing we're going to do, we're going to sequence your tumor and determine the molecular characteristics of that tumor in a very targeted treatment. We do now pharmacogenomics testing, the combination of pharmacology and genomics. All newborn babies born at Inova now, if you come in, you can opt in free of charge. Cheek swab, a sequence. We can tell parents, pediatricians on a 7-gene, 21-drug panel if their children are actually toxic to certain types of drugs or specific dosing. So a child would never get codeine if we can tell a parent and pediatricians that there's actually toxicity there, so they never get it. So the ecosystem, again, reimbursement ecosystem has to catch up to all this because it's just not there. I think the other interesting area is with the FDA. We were in a meeting with the FDA recently, and as you know, when things get termed to be medical devices, you're in a whole different world. And what's a medical device, what's not a medical device is very important. How quickly can the FDA react in this environment? Is an app, for example, considered a medical device? I think there's lots of interpretation. I think we're going to have to be very good from a policy and regulatory standpoint to take advantage of the advancements in science and technology, importantly, and at the same time appropriately regulate where it's necessary to do so. But I think this is, again, a whole new exciting area and important area to build out the ecosystem.
Doctor?
I think there are two areas that I'd like to highlight. One is the whole cross-state rules, and Dan talked about it. We're no longer really defined by state in healthcare, and we need to figure out how to get the rules that are more effective so that we can implement faster and cross state lines. Dan talked about that a little bit, but it's big in telehealth. There are still 4 states that you can't do telehealth visits by state laws, and then there's variations across the states. And so we need to do more work in regionalization. And then the second one is how do we effectively get incredible pharmaceutical solutions like hepatitis C treatment programs that are so very expensive into the hands of everybody so that we can improve the downstream care expense, but the upstream cost is really high, and we need to figure out how to do that.
Great. Marie?
Yeah, and I think from the health plan perspective, pharmacy costs rises to the top for us. We see so many of our members, our enrollees, with chronic conditions, and we're tied to whatever the cost of those drugs are that those members need to treat their care and treat it appropriately. So like all the health plan carriers out there, pharmacy care is paramount on our list. We work very closely with our pharmacy providers just to see how we can bring the best generic alternatives to market so that our members have drug choices that will help to treat their conditions. The efficacy is there, and so nothing is being compromised as they move to lower cost alternatives. So I think that's the challenge for us, and there are some timelines around when some of these lower cost generics are available that impacts our ability to offer our members the most affordable care. So that's the number one concern for us at this time. And I think we also pay very close attention to the discussion around I don't want to say this wrong, but how we're looking at the genetic evolution, and we're paying very close attention to that, and we are looking at the challenges. We're paying close attention to the debate, and we want all the stakeholders to know that we will step in and we will support as appropriate. But there are a lot of discussions going on there, and we want to make sure we're supporting.
Liz?
Sure, I would say we need to continue to be sensitive in when our policy making to be thinking about the incentives that we're trying to align providers or health plans. We mentioned earlier when patients move from plan to plan, or even from employer to employer, maybe move them from plan to plan. It's hard for providers or plans to be incented to invest long-term because we invest upfront on wellness and prevention only to not have
Mark?
I do see this as a really exciting time because as a society, we've invested a lot in therapeutics innovation over the last several decades. And now I see us investing a lot in care delivery innovations. And we're going to produce lots of really cool results that have huge impact. And it's going to be a fast-paced change. But there are counter incentives where sometimes the commercial community can't arbitrage that. And state governments, local governments maybe could. And so I would like to throw out the challenge to the governments to say, where you see practical innovations, be an early adopter. You're a large employer. You can take advantage of some of these new things that maybe don't have the dynamic of, well, we can't overinvest in prevention because we're going to have turnover. So be one of the models of how these technologies get adopted, get utilized, and just a little bit of a commercial for ourselves. I mean, we're developing a program. We offer a solution that through spending $200 to maybe $300 more on the dental side, you can save $2,800 a year in managing a diabetes patient. That's really profound savings. And yet the insurance plumbing doesn't exist to really make that an easy transaction. So in some cases, maybe that's an example, maybe there are others, but let's think about state governments and local governments as potential early adopters to try to work through some of these friction points as examples of early successes.
Well, thank you, panel. We appreciate it. Please join me in thanking our panel today.